All right, let's dive into a really high-yield topic for your anesthesia finals. Adult congenital heart disease, or ACHD. This is a field that's growing fast, and it's absolutely crucial that we know how to handle it. We're going to break it all down for you, nice and simple. So first up, why is this so important now? Well, because of this number. Over 90% of children who are born with congenital heart disease are now surviving well into adulthood. I mean, that's just an incredible medical success story. But what it means for us is there's this whole new and really complex group of patients showing up on our operating lists.
And that leads us to the big question, right? These patients aren't just in specialist cardiac centers anymore. They're coming in for all sorts of surgeries everywhere. So are you ready for them? Well, stick with me, and by the end of this, you're going to have a solid game plan.
So here's our roadmap. We'll start by looking at just how big this challenge is. Then, we'll give you a really simple framework to classify these patients. After that, we'll dive into the core physiology, shunts and flows, and then cover the risks that apply to almost all of them. We'll wrap it up with a practical checklist for you to use and touch on the super high-stakes topic of pregnancy.
Okay, first, let's just get a sense of the sheer scale we're dealing with. This isn't some niche topic you might see once in a blue moon. It's becoming part of our day-to-day. Just think about this for a second. In the UK alone, there are now more than 250,000 adults living with congenital heart disease. That number is actually bigger than the entire population of kids with these conditions. So yeah, you will see these patients.
Okay, so this all sounds a bit overwhelming, right? A huge range of conditions. How do you even start to think about them? Well, the key is to use this framework. Forget the complex anatomy for a second and just think in terms of simple, moderate, and severe complexity. This is your starting point.
In this table right here, this is your mental model. This is how you start to stratify the risk. It immediately helps you figure out, okay, is this someone I can safely manage here, or do I need to pick up the phone to a specialist center right now?
Simple lesions, well, they're pretty much what they sound like. Think of a repaired hole in the heart, like an ASD or VSD, with no leftover problems. But, and this is a big but, don't get complacent. Even these low-risk folks have a higher chance of developing arrhythmias later in life, so they're never quite normal.
Now we're stepping it up into the moderate group, and this is where things get serious. Someone with a repaired tetralogy of Fallot might look perfectly fine, but they're carrying a lifelong risk of dangerous arrhythmias and even sudden death. The take-home message for this entire category is simple. You have to discuss these patients with their specialist center before you do anything.
And then we have the severe complexity group. If a patient has any cyanosis, any at all, they're automatically in this category. This is where you find really unique physiologies, like the Fontan circulation, where the blood flow to the lungs is completely passive and incredibly sensitive to every little thing we do with anesthesia. These are the highest risk patients, and they must be managed in a specialist center unless it's a true life or death emergency.
Right. To anesthetize these patients safely, especially the ones with shunts, you have got to be on top of the physiology. It's all a balancing act between the lung circulation and the body's circulation.
And this slide, this is your secret weapon. This shows you how to manage that balance. See, while our drugs often affect both circulations, it's our control over ventilation that gives us this amazing, specific tool to change the pulmonary vascular resistance, or PVR. Too little oxygen or too much CO2 will squeeze those lung vessels, while giving more oxygen and blowing off CO2 will open them up. Mastering this table is absolutely non-negotiable.
Now, the most extreme example of all this is Eisenmenger's syndrome. This is the end stage. The pressure in the lungs has gotten so high that the shunt actually flips and goes the wrong way. The perioperative mortality is a staggering 20%. Let that sink in. 1 in 5. So your absolute #1 priority is to keep their blood pressure up. Any drop in systemic vascular resistance will make the shunt worse, make them more blue, and can cause a rapid, catastrophic collapse.
Okay, so we've talked about the specific lesions, but now let's talk about the dangers that cut across pretty much all ACHD patients. These need to be on your radar every single time.
#1 on your list of worries should always be arrhythmias. In fact, it's the most common reason these patients get admitted to the hospital. All those surgical scars and stretched out heart chambers are a perfect setup for electrical problems. And here's the critical bit. These patients often have a fixed cardiac output. They desperately need that normal sinus rhythm to fill their ventricles properly, so they tolerate losing it really, really badly.
These patients are also very prone to bleeding, and it's not just one thing.
It's a perfect storm. Being chronically blue can create abnormal blood vessels. Many are on blood thinners. Heart failure can back up into the liver and mess with clotting factors. And long-term low oxygen also messes up platelets. You just have to expect it and plan for it.
And here's the really tricky part. At the exact same time they're at risk of bleeding, they're also at a huge risk of clotting. That chronic low oxygen makes their blood thick and sludgy. And in places where blood flow is slow, like in a giant atrium or a Fontan circuit, clots can easily form. So it's this incredibly difficult balancing act you have to manage.
Okay, I know that was a ton of theory, so let's pull it all together and make it super practical. Think of this next slide as your cognitive aid, your go-to checklist for every single ACHD patient.
Before you even think about drawing up your drugs, just mentally run through this list. 1. What's the exact anatomy and physiology? 2. Are there any leftover problems from their surgery? 3. How are my anesthetic drugs going to affect this specific heart? 4. What's my ventilation plan to control blood flow? 5. Am I ready for arrhythmias? 6. Do they need antibiotics or blood thinners? And 7. How high is the bleeding risk?
All right, one last really important scenario we have to cover is pregnancy. In the UK, cardiac disease is the #1 cause of indirect maternal death, and a big chunk of that is from ACHD. This is as high stakes as it gets and needs a whole team approach.
The risk here varies wildly depending on the patient's condition. But just look at that high-risk category. The key message is pulmonary hypertension. For a patient with severe pulmonary hypertension or Eisenmenger's, the maternal mortality rate can be as high as 30 to 50%. That's staggering. It just highlights why these patients absolutely need to be managed in a specialist center from before they even get pregnant.
So, we'll leave you with this. Your next patient with ACHD is on tomorrow's list. You've read their old notes, you're about to pick up the phone to talk to their cardiologist or specialist anaesthetist. After everything we've just talked about, what's going to be your first, most important question to help you build a safe plan?
And that brings us to the end of our review. All this information was based on a fantastic article from 2017 in BJA Education by Wheel and Kelleher. It's a great read if you want to go deeper. Thanks so much for joining us.